Hello and welcome to our module on immunosuppressants. In this module, we're going to talk about how the immune system mounts a response against organ transplant patients. And this is the number one reason that we use these immunosuppressants is to reduce the immune response against the transplant. Here's a list of immunosuppressants that we're going to talk about today. Here's the physiology of the immune response. As you could see, I tried to put it in one page just to help you learn it all in order. So as you can see, the antigen over here is going to activate on a T cell receptor. And this T cell receptor is usually going to be on a CD4 cell, or at least for this case it will be. This T cell receptor has an internal signal that is triggered by the CD3 portion of it. And this CD3 portion can actually go and activate calcineurin. Calcineurin is a very important molecule because it can actually transport into the nucleus and activate nuclear transcription factors. And these nuclear transcription factors, the one that we're going to be talking about, is going to be called NFAT. NFAT stands for nuclear factor of activated T cells. Duh. So this NFAT is going to be important because it actually promotes the signal of NF-kappa beta, or NF-kappa B, I'm sorry. And this NF-kappa B is pretty much the most important gene in the immune system. It actually expresses a lot of stuff, one of which is going to be the inflammatory cytokine production. So these cytokines, the most important one that we're going to talk about is going to be IL-2. IL-2 is very important for activating T cells, and T cells are going to be important for rejection or transplant rejection. And you just keep in mind that this IL-2 actually has an autocrine function, so it'll also activate the T cell that it's initially triggered, as well as other T cells. So here's how it would work. IL-2 will actually bind onto an IL-2 receptor, of course. And this IL-2 receptor has an internal signal that activates mTOR. Now mTOR is going to be very important because this is where we're going to use another drug called rapamycin. mTOR just means the mechanical target of rapamycin. As you can see over here, that's the brand name of Sirolimus. So what mTOR is going to do is going to go in to the cell and work on nuclear factors, and these nuclear factors will cause T cell proliferation. Let's start off by talking about the world's first monoclonal antibody. And when you think of monoclonal antibody, I want you to think of an antibody that targets a specific protein inside of our immune system or otherwise. So this monoclonal antibody, I know it's a monoclonal antibody because it ends with Monab. In the future, from then on, we started naming them with just MAB, M-A-B, just to identify when we're talking about monoclonal antibody. But this one's the only one that actually has Monab, and it binds onto C3. So the first one is actually binding to the first part of the immune response. And the CD3 is going to be, as we talked about earlier, the initial step in activating the internal signal. So you see an antigen over here cannot transmit an internal signal to calcineurin. The biggest side effect that we have to watch out for is an initial hypercytokinemia. In other words, that this antibody over here can actually trigger the CD3 at the beginning, and this will actually increase the calcineurin, and it'll actually make more T cell proliferation, and you get a lot of symptoms as if you're very, very sick, like fever, chills, diarrhea, and maybe symptoms like you're going through septic shock, like flash pulmonary edema, cardiac arrest, and shock. So it's always very important to give steroids to these patients before you give Muromonab. However, it's not very often used and it's not very heavily tested. So just knowing that it can cause hypercytokinemia and you need to give steroids is more than enough. Again, it also causes leukopenia. It can cause an inhibition of T cell proliferation in the long term. All right, moving on to cyclosporine. Cyclosporine is one of the more heavily tested ones, so you probably want to pay very close attention to here. Cyclosporine binds onto a protein called cyclophilin, and that's very easy to remember because cyclophilin has cyclo in its name, so it binds onto cycloprotein, and philin, which means lover. So it's a cyclo lover. It loves cyclosporine. So cyclosporine and the cyclophilin complex goes together, and they inhibit calcineurin. So they work together and inhibit calcineurin by sequestering it. So you never really get the activation of NFAT gene, which you never get to promote the NF-kappa B, and you never produce IL-2. Some important adverse effects, probably the most important one, is nephrotoxicity. That doesn't mean we won't use cyclosporine for kidney failure patients that received a transplant. We still often do, but we just have to use it in smaller doses. And we also have to watch out for that. Cyclosporine is very, very dangerous for the kidneys. It's the number one side effect. Another one that's very unique for it is going to be gingival hyperplasia. This is often seen in cyclosporine and some of the anti-epileptics, so it's very rare and it's often testable right there. Other symptoms that it can cause is hirsutism, which just means hair, hypertension, neurotoxicity, and hyperlipidemia. Tacrolimus, its initial name was FK506 by the scientists that discovered it, and that's why you'll see in the mechanism it needs to bind to FK binding protein. FK just means tacrolimus in this case, because initially it was just called FK506. Now this tacrolimus FKB protein is going to be working together to inhibit calcineurin. So it works very similar to cyclosporine, but instead of binding into cyclophilin, it binds onto FK binding protein. So that's just very important for you to know. And that is going to inhibit cyclosporine. And then the same way you're going to get no IL-2 production and no T cell proliferation. Just like cyclosporine as well, you get a lot of nephrotoxicity. But different from cyclosporine is that it can cause stuff like insulin resistance in diabetes, and it can cause neurotoxicity, which is similar to cyclosporine. So just look at how similar it is. You could see that the biggest difference is going to be the mechanism, which one it binds to, and that's just going to be FKBP for tacrolimus, and that tends to be what the questions are going to ask you. Corticosteroids are one of the more heavily tested ones again because they're just used in so many different modules. Let's just take a look at the mechanism again as we are moving down. Calcineurin, we know that activates NFAT, which is a promoter of NF-kappa B. Now NF-kappa B is important because it produces a lot of the cytokines that we need for T cell proliferation to mount an immune response. And this is very bad when you have someone with a transplanted organ. Now, corticosteroids work by binding on to intracellular receptors. This is a very commonly asked question. You have to understand that corticosteroids are fat soluble, so they'll phase right through the cell surface membrane. And when they phase right through the cell surface membrane, they're going to bind onto these intracellular receptors. These intracellular receptors will work in a complex that inhibits NF-kappa B. And inhibiting NF-kappa B means that you're going to inhibit all of the lymphocytes, your entire immune system. But that's not all it does. It affects different parts of your body as well. More specifically, it affects your bones, it affects your muscles, and it affects your skin. So let's just go through it. Your bones are going to be inhibited because it's going to inhibit the osteoclasts. Osteoclasts are just mature macrophages that are found in your bone, and they're very important for remodeling. So your bones are going to get osteoporosis, or just porous bones, and eventually they'll start collapsing on themselves. When they start collapsing on themselves, they're going to make no more room for arteries because you need to remodel them to make them strong for over the long run, and you're not able to do that. So eventually they're just going to collapse, and they're not going to make any room for arteries, and you can get avascular necrosis of the femur because you could imagine the weight, a lot of the weight is right there on the femur, and the femur is at severe risk of losing its blood supply. Another very commonly asked question is Cushing syndrome. This is what happens when someone is on high-dose steroids for a very long time. So Cushing syndrome often presents as obesity, so you've got a whole lot of central obesity, but also thin arms. You've also got moon face. Your face is going to be a little bit more round, and you've got that buffalo hump in the back. You also want to look out for red striae. This red striae is just a side effect of having very thin skin. That's one of the more common side effects with long-term use. Something else that it causes is hyperglycemia, hyperlipidemia, muscle loss, which is shown by the thin arms compared to your central obesity, and then hypertension. Daclizumab and Basiliximab. The way I memorize these is duck when you see the basilisk. And when I think of a basilisk, I think of it as the gatekeeper. The gatekeeper for what? The most important one, the most important receptor of all, the IL-2 receptor. Because this IL-2 receptor is the one that is pretty much gatekeeping the T cell proliferation in general. Just remember that IL-2 is important for T cell proliferation. And these two, Daclizumab and Basiliximab, are going to block the IL-2 receptor. Now here's just a way that we can learn a little bit about monoclonal antibodies. They can be broken down into different things based on their names. So the LI lets me know that it works on the immune system because LI stands for lymphocytic. The ZU, the U sound, is going to be human, the vowel, and the XI means chimeric. XI is pronounced chi in Latin or Greek, and so you think of chimeric. And then MAB just stands for monoclonal antibody. So that kind of helps me narrow it down on how it works. The adverse effects are not very important. It just causes edema, hypertension, and tremors, but they almost never ask you about that. They're more likely going to ask you about how it works, and you just need to remember that it blocks the IL-2 receptor. I put you over here the basilisk from Harry Potter. Just imagine the basilisk is just coming at you, and then you have to duck underneath him, and then you'll remember Daclizumab and Basiliximab. All right, let's talk about Sirolimus. Sirolimus is going to be very similar to Tacrolimus, which is why they have very similar names. But I think one of the more important things is that you need to understand that Sirolimus and Rapamycin are the same thing. Rapamycin is just a brand name, but we just use them interchangeably often, and it's one of the few brand names that you actually have to memorize. Now, Sirolimus binds onto FK binding protein. Even though it's not FK506, i.e. Tacrolimus, it still binds onto it. But when it binds onto FK binding protein, instead of inhibiting cyclosporine, it actually is going to inhibit mTOR. mTOR is very easy to remember because mTOR stands for mechanical target of rapamycin. And we're talking about Sirolimus or rapamycin in this case. So what you need to know about Sirolimus is that through this pathway, it's actually safe for the kidneys. If the patient if you want the kidneys to survive, you're going to use Sirolimus, right? So it's just an alternative to cyclosporine or tacrolimus. It's just a better alternative, especially if they have failing kidneys at this point. It can also be used in stents to prevent endothelial growth. So just preventing growth in general. It's not necessarily specific for T cells. It also inhibits endothelial growth. And of course, the adverse effect is going to be pancytopenia. It just inhibits T cell production. So you would get a decrease in cytopenia, which just means a decrease in cells inside of your blood. It can also cause insulin resistance and hyperlipidemia, but that's not often tested. I try to remember it with Sir Rapsalot and his entourage or entourage, but just think of entourage. So this will remind you of Sirolimus, Rapamycin, and mTOR. All right, let's talk about mycophenolate mofetil. So mycophenolate mofetil actually works by inhibiting IMP dehydrogenase. IMP dehydrogenase stands for inosine monophosphate dehydrogenase. If you remember vaguely from biochemistry, if you can just review that, you'll remember that IMP dehydrogenase turns a lot of the inosine monophosphate into xanthine monophosphate, which is very important for purine synthesis. And if you don't have purine synthesis, you can't make RNA or DNA for that matter. And this is very important for synthesis of new cells or proliferation. So that's just the general mechanism of it. What you want to kind of remember is that it only works on isoform 2. So you only really get inhibition of white blood cells without actually affecting the rest of your body. You don't get a lot of the symptoms of GI problems or whatnot from it. Now, a notable side effect of this drug is going to be a cytomegalovirus infection. This virus infects a lot of the general population, but most people with an intact immune system never really experience it. But whenever you take this drug, it actually for some reason or another, it actually reactivates CMV, and then you get these owl eye inclusions over here. If you ever see these little owl eyes inclusions, you want to think of CMV infections, which is a very common side effect of this. Other effects of it is going to be pancytopenia, of course, because your white blood cells are going to be inhibited. Your GI is going to have some problems because it's constantly replicating in your GI system with the abrasion of the feces or whatever. So you would have a lot of diarrhea because your GI is not able to proliferate as much. You just can't proliferate from the DNA's perspective. You can't make purines for the DNA or the RNA synthesis. Now let's talk about azathioprine. Azathioprine, I want you to think of thio. Thio is Latin for sulfur, and prine, which is just purine. So you want to think of a sulfur purine drug. So another way that they could use it is instead of using thio, they can use mercapto, which also means just sulfur. So if you ever see azathioprine or 6-mercaptopurine, these are pretty much the same effect. The only difference is azathioprine is a prodrug. It gets turned into 6-mercaptopurine inside of your body. And once it becomes 6-mercaptopurine, 6-mercaptopurine is just a purine analog, but it has a sulfur right here. It has a sulfur right here instead of the NH2 of the adenine. So it doesn't really work as well, and it just tricks your body into thinking that this is an adenine, for example, and it gets incorporated and inhibits proliferation through the DNA. So you're also, in this case, inhibiting the proliferation. It can be used not only for transplant, but it can also be used for chemotherapy, because it doesn't just inhibit the proliferation of white blood cells, but it also inhibits the proliferation of cells in general. So you could actually use it for chemotherapy. And it can often cause pancytopenia, of course, because your white blood cells cannot proliferate, neither can your red blood cells for that matter. Now, some drug interactions that they love to ask you about is 6-mercaptopurine can be degraded by xanthine oxidase. Now, if you've studied ahead, you'll know that gout is, we have a drug called allopurinol. This is a gout drug, and this allopurinol inhibits xanthine oxidase, and it prevents uric acid from formation. So you can't really turn xanthine into uric acid, but you also can't turn 6-mercaptopurine into uric acid. So you get a buildup of 6-mercaptopurine, and this buildup of 6-mercaptopurine means you get an increase in adverse effects, and that just means you get an even worse immunosuppression. So you want to think of allopurinol. Don't give allopurinol with people taking either azathioprine or 6-mercaptopurine. How are you going to use all of this information? I'm going to tell you right now that the mechanism is probably the most important thing. Mechanism. The adverse effects are very different, or very similar to each other, so you don't really need to know too much about them. Maybe just the specific ones like Sirolimus has no nephrotoxicity, so it's good to give patients with severe kidney failure. You have to also remember just some weirder side effects like cyclosporine. Cyclosporine causes gingival hyperplasia, which is a very rare side effect in general, and so you want to kind of look out for it because it's very unique to this drug and some epileptic drugs. I think what's more important than actually learning about each drug is going to be the physiology. Just understanding the physiology of each step of the way and just knowing where to put the drugs in that physiology pathway it's going to be a lot easier than just trying to memorize each drug separately. So I would highly recommend just trying to draw out the physiology and putting the drugs where they belong. Let's take a look over here at an example question. We've got a 50-year-old renal transplant patient who's presenting with inflammation in his first right metatarsal joint. So he's got a right metatarsal joint. He's got a diagnosis of acute gout attack is made, and the patient asks you about managing his gout so that further attacks do not occur. Knowing that the mainstay of gout treatment is allopurinol, what immunosuppressants are now contraindicated in this patient? So you, if you didn't think azathioprine, you might want to review this a little bit more. You got to think azathioprine or 6-mercaptopurine right away, because allopurinol will inhibit xanthine oxidase, and this will prevent the metabolism of azathioprine to a more benign compound.